about this initiative. So we conceived this idea with the premise that everything starts with a discussion. So there are so many issues that influence the profession of occupational therapy in India. We need to do a lot. We have a long way to go. But then, in order to find the directions and to understand the issues that influence our practice in India, we need to discuss and debate on a lot of things. So with that premise, we thought everything starts with a discussion. So why can't we provide a platform for the professionals to discuss? And that discussion will generate more discussion, will bring in more different perspectives. And when multiple minds collide, some magic will happen. So that's the understanding. And then every time we're still struggling to determine the frequency of this chat. We decided to start off with every alternate month, and we try to go for every month. And then we really need to see the interest among the stakeholders in joining and participating in this conversation. The reason I'm talking about that is, in one of the previous ones we scheduled in May, we just got 2 registrants. Probably it's a holiday time. It may be a bad timing, but I think without multiple people present in this call, the perspectives that we bring to the table may be very limited. So more the people, more different ideas being shared, more valuable will be the discussion. As well as, when it gets posted on social media, anyone who listen to this discussion in the future will also benefit from it. So having said that, I invite each of you to actively participate in the conversation. The idea behind this chat is basically every time we will come up with a topic, and we strongly encourage the attendees to stick to the topic so that, when we post these stuff out there with the title, we are not misleading people. So try to stick to the core topic. Of course, there may be some deviations if it's a related information, but as long as we stick to the core of the discussion, it'll be great. And please spread the word out so that any professionally minded OT practitioner can join, or even, for joining this chat, students are also welcome if they have new perspective to share. So please spread the word and help us, continue this initiative in a successful manner. So as of now, we have decided to do this once every quarter, but if there is a surge in interest, we will reconsider that. Having said that, after the next chat session will be sometime in October. And then the following will be like every 3 months. So October, Jan, April, July, and October are the months that we are planning to do it now. Without further ado, I'm going to turn the control over to our member, Kriba Priscilla, to guide us through the discussion on the topic of interprofessional collaboration in OT practice in India. Kriba, please take over.
Thank you, sir. So can you able to hear me now?
Yes.
Okay, so thank you. Good evening, everyone. I'm Kriba Priscilla, member Indian Occupational Therapy Think Tank. So I welcome all of you for this discussion on interprofessional collaboration in OT practice. So as you all know, and also Dr. Karthik said, this is a Saturday night chat we usually have, where like-minded occupational therapists who are passionate about empowering OT in India join together, have discussion about the major concerns that are in the OT practice, education, and also in research. So this week we have chosen about interprofessional collaborations in India. So I would like to invite the participants to introduce yourself and also tell me about the setting that you're working in. That is, if you are in a educational setting or if you are in a clinical setting, please do let us know what kind of collaboration practice you are into. Is it a multidisciplinary team that you're working part of, or it is a interdisciplinary team, or what kind of team it is in? So that will be easy for us to have a good discussion. So I'll just go according to the name list that's seen in the screen. So Maheshwari, could you introduce yourself, Dr. Maheshwari?
Hello, good evening, everyone. I take indeed pleasure in joining this platform and sharing my knowledge. I'm a PG student from SRM. I have chosen MOT in sensory integration therapy. I'm doing MOT first year. So, as you all know, SRM is the interdisciplinary setup where we collide with all other professionals but not in terms of sharing the same goals. We work separately, and in terms of patient, if there is any need, we'll share our goals, like what is the current level of the patient and what we have to do in order to improve the patient. So once again, I thank for this great opportunity.
Thank you, Maheshwari, for joining us. And I would say that is more of an multidisciplinary approach, what we are doing there. Okay, and I'll move on to Nidhi. Dr. Nidhi, could you introduce yourself, please? I think we are continuously seeing Nidhi in all of our Saturday night chat. It's great to see you again, Dr. Nidhi.
Thank you, ma'am. Actually, I'm in a traffic, so I apologize for all the noise disturbance that will be there. Okay, I am Nidhi. I've currently started working as an assistant professor in Cambridge College of Occupational Therapy in Coimbatore. And my experience so far has again been working in a multidisciplinary setup rather than an interdisciplinary setup. So I have gained perspectives on working with the pediatric population, working with the adult neurological and rehabilitation population, and with the adult mental health population.
Okay, that's great. That's great. Thank you for joining us today. And next, I have screen Dr. Odette Gomes. I hope I pronounced the name correctly. Can you please introduce yourself?
Yes, you pronounced my name perfectly.
I did?
Yeah, good evening.
Yeah.
Good evening. I have retired a couple of years now, but I just thought let me just log in and listen to what the current generation or the new generation is doing. And it's so nice that you have this think tank. Thanks, Karthik, for everything that you've been doing for the overseas people, and subsequently also for those in India. Yes, you need to have these discussions. We've always worked in multidisciplinary. Currently, I consult at a palliative care center. So we have doctors and nurses. There is a physiotherapist as well. And I always say, your work is what should explain your profession. So when they see what you do and how you bring about quality of life in the cases that you see, that's how they kind of know so much about OT. I've also been certified lymphedema therapist through a course, which I did, of course, after I retired. But I just found that need to be there with the cases that I was seeing. I didn't really have so much of exposure to cancer treating in public hospital that I worked in. But it's great to see you and listen to everybody.
That's great. Thank you for joining us, ma'am. Yeah. So next I have screen Dr. Thirumurugam. Sir, could you please introduce yourself?
Yeah, thank you. So, good evening, everyone. So, myself, Thirumugam, you can call me Thiru, and I'm currently based in Hyderabad. I did my graduation from CMC Vellore, and I worked there for about 2 years. Then, post which I joined my public health. So, I went into the public health stream, and I did some research activities in disability. So, since then, I've been actively working in research related activities, public health as a whole, and disability as one of the part. And I also do some monitoring and evaluation activities of various public health programs, including NRHM, and I also consult with few NGOs, and I also do some international evaluations and for disability related programs. So that's in short about me, and I'm currently working with Clarivate as a healthcare consultant. So I do consulting practice for life sciences stream as well. So nice to meet you all.
That's great. Thank you for joining us, sir. Now, next I think we have one more participant in the list, Dr. Murali Krishnan, sir. Could you please introduce yourself? We know about sir very well, but still for everyone in the meeting, sir, could you please introduce yourself?
Hi, everyone. Very good evening. Just reaching. So, I'm Murali, basically in Chennai. Did my UG from Savita and PG from TNMC Mumbai. Presently, I am running my center in Chennai, which is Fund and Life Skills Enhancement Center, and also associated with IOTT from the beginning of it. I'm very glad to meet you all. Let's look forward to a wonderful discussion.
Yes, thank you, sir. And we have another participant here. So Dr. Raja Rajeshwari ma'am. So we have a senior person again. So ma'am, could you please introduce yourself? Which type of setting you're working in?
Yes, Prabha. Thank you. Thank you so much for letting me introduce myself. This is Raj Rajeshwari here, and I'm a school-based occupational therapist. I've been working in that setup for the past 7 years, named HLC International School, and I had been working for the past 20 years in the pediatric field. Thank you.
So
Nice to be part of this.
yeah, what kind of collaboration do you have there, ma'am? So do you collaborate with other professionals in the setting?
Yes, we do, and we are. There are 2 occupational therapists there, and we pretty much take care of the whole school. So for the mainstream classrooms and also children with needs, and also parental empowerment is the basic and a major dream that I'm living through there, where we are able to proactively handle the early intervention by handling KG children and giving them the developmental domains appropriate, and also educating parents, and in all the other areas like we always do clinically.
That's great. That's great. Thank you. Thank you. I think we are done with the introduction. So as we all know how interprofessional collaboration is very much important. So that's the first and foremost thing that we need to have a good client satisfaction and also to have a job satisfaction. So that being said, the first question or first discussion for today is, are we collaborating enough in the Indian setup? Are we collaborating enough with the other professionals in the practice, in education and research? So first, let's go with the practice. And I invite the participants to come up with your perspective about how we are collaborating. And if we are collaborating enough, if you could tell me the areas, that would be great. If not, could you tell me the reasons and challenges why we are not able to collaborate enough in the practice? Anybody? No, I would like to invite anyone who wants to share the thoughts. So you're muted.
Okay.
Ah.
Okay. Can you hear me? Okay.
Yes. Yes.
Yeah. Given the silence, I will go first. Again, I'm totally like out of the Indian context of practice for a long time now, but I can generally share some of my thoughts related to interprofessional practice and some of the challenges associated with it. So currently I work as an assistant professor and field coordinator at the University of Texas Medical Branch, and we do have a student-run clinic here. And in one of the weekdays, we try to do an interprofessional clinic where we work with School of Medicine folks and School of Nursing. People will be there, all department staffs and students will be there, and our students will also be there. The way that we approach this interprofessional practice collaboration is basically we focus on client outcomes. So we will have what we call as a huddle room meeting where whatever the number of patients that are scheduled for that day to the clinic, we will review each cases. And then say, for example, patient X name is being announced there, then School of Medicine will say what they are doing with that patient from their side. And then OT will say, oh, we are looking for we are seeing the patient for XYZ problems. And then social worker will chip in and then see is there any need from our side. And PT will say, and also meanwhile, during the discussion, the School of Medicine say, oh, they have this, I sense some sort of depression, anxiety symptoms last weekend. Then, okay, so there's a psychologist available. So, okay, psychologist will say, okay, send me the patient to me. I will do a screening. And then if needed, I can do an evaluation. So it's more of, what the client needs. Like we'll just put the client in the center and then see how we all can contribute to it. And sometimes, what the other provider has seen might give us some more directions in terms of what we can do more in order to help the patient. So that is the approach that's being used. Having said that, everything looks very positive on that side. But again, we still believe that even in the US, there's still in a lot of settings, the practice are very siloed. Like OTs, they do their part and then just can walk away. And then in skilled nursing facility type of settings where, the nursing homes type of setting, inpatient rehab settings, when I worked here like several years ago in clinical settings, what we do is we do have a weekly case meeting, where again, the same thing, we just kind of review each case and then say, whether they are progressing or not, and then what OT is doing, what PT is doing. It is pretty much the rehab department meeting. So it's like OT-PT speech will talk about the patient, but then in the student run setting, it's a little bit more broader. But I think, even the US, we are still trying to get there. It is not optimal. Still, we can do a lot more. Having said that, if you just go to where there are multiple departments there, if you go to School of Medicine in my university for that reason, ask them, what do you think OTs will do with the patients if you refer them? They may have a very broad idea, or they do not have an idea. They know that there is a profession called OT, and that's what even my survey study said when I surveyed the medical professionals in South India. A lot of them heard of the word or phrase occupational therapy. They know there is a profession. They know somehow that it's somehow related to disability and rehabilitation, but they do not know what type of settings we work, what we do, how we help patients, what kind of problems they should refer the patients to us, and all those things. So still, there is a lot of gap, and I think we need to work with others with keeping clients in the center in order to make ourselves more visible on one side, and also, again, as you said, it will lead to effective client outcomes and client satisfaction, and that should be the ultimate goal. I'll let others share their perspectives.
The reasons that you think are the challenges, or anybody else in the meeting, what are the challenges that we face in collaborating enough with the other professionals? Anybody else would like to go? Why are we not able to collaborate enough with the other professionals?
Hi. Initially, while during the introduction, I skipped the. Okay, now I think about it. I skipped the part where the collaboration aspect was. Like other than the teaching, I was very much into teaching. Now I've continuously been in the practice, and I have always been collaborating with lots of people in that aspect. But have I been successful, or have I been 100% collaborating with people? I still question that to myself. I do a lot of work with psychiatrists, neurologists, and orthopedicians. At the same time, even the in-depth field where we are working in the pediatrics, where psychologists specialize, and schools, parent groups and stuff. But the main challenge where collaboration in general, let it be a psychiatry or a neuro or pediatrics, the major hurdle or major stoppage from collaboration will be our own self, where we are not open for the much needed collaboration as such from that aspect, because we still complain that others are not accepting us, or others are not reaching out to us, and it's 50-50. As much as they are not reaching out to us, we are not reaching out to them as well. So if we take a step forward and then meet a developmental pediatrician and tell, I will do these things, and we can work together, and they would definitely be happy to collaborate, because they are the first point of contact most of the times, and they are anyway in the rehabilitation team, they are in the top lead. At the same time, it is the child is going to go to them, from there diversify to a speech or OT or anywhere else. So it is us reaching out to them and telling them that, okay, I'm available, I'm here in this place, I can help you in this particular area of work for this particular kid. We'll sort out the issue. At the same time, once we get the referral, getting back to the people who have referred you, mostly the clinicians, telling them, sorry?
Yeah, I said that's very rare. We don't go back to the source of referral and we tell them what we're currently doing. Yeah.
Yeah. Like they call them for review every 3 months, every month, but how often do we give a report stating, okay, in 3 months, this is what the improvement is. This 3 months, this is what the improvement or challenges I'm facing. Can you help me with this behavioral issue, which after therapy also not getting all right, and that's most of it. So if we can communicate or open our communication channel from our end, probably others will also open up. And I also see Gomes ma'am there.
Yeah.
Sorry, I just. I'm open for others. Please go ahead and then.
So, Dr. Murali sir is trying to say that OTIS should initiate or since we are most of the time we are the first point of contact, if we could initiate the collaboration, it would happen. So that's one of the challenges Sir has come up with. So anybody else is seeing another challenge, or do you feel any other problems in collaborating with the others?
The problem is that, yes, we don't go back to them. Hi, Murli. When you assess somebody, or if the person is referred, you assess, you treat, you do whatever you want, but you have to share it with the doctor or the person who has referred. Then they know what you are doing. If you don't do that, they have no clue what you are doing. And therefore, there can not be any discussion further as to what is the next step. I mean, I used to face this when I was younger at Nair Hospital. And, when you went back and you said, this is what I am finding in the patient. And then he says, what do you mean you are finding? I said, when I assessed, this is what I found. And you are finding, we didn't have so much of interventions at that time, the investigation procedures and whatever. So it was a lot of clinical assessment that you did. So he says, you mean to say you have actually assessed the patient? I said, then what did you think we were doing? I think, no, you're all pretty girls, OTPT pretty girls, come and do things and go. So see, their perspective also was so different. And then once you discussed with them as to what your findings were, what you were planning to do, then you just found a different level of communication. And then they would come back and ask you, can you do this? Especially individual muscle testing, we just take it for granted. And they are in awe that we can actually put some 2 and 3 and 4 plus and whatever to all those muscles that are there. We take it for granted. But then they are in awe. I remember in ortho also, and then when the resident presented, the honorary would say, I'm sure you never did any of this. She must have done it because they know it and you guys don't know it. But what I'm trying to say is, yes, there has to be a conversation, a dialogue, a discussion. You may not always be right. You may not be right. But you can always discuss. So, and once they know what you know and what you are planning to do, then I'm sure there will be this collaborative effect, or whatever you may call it, interdisciplinary and all. Because we can't do without the surgeon can't do without us. Or the medical profession. We have to work in a team. We have to work in a team. And unless they know what you're doing, what's going to happen? They'll refer and just leave it. And it makes a big difference when you write, even in private, if you're assessed a person and you write your, a report about it and just send it with the patient to the doctor, even if that doctor has not referred you, there is a big difference, because they will say, okay, they are actually having a protocol for assessment and a follow-up and an advice as to what is the next step of therapy.
I agree with you, ma'am. I completely agree with you. So in the practice that where I am working as well, so we would go talk to the doctor in the beginning and we don't follow frequently. So the same, I've faced the same sentence where they've said, like, you guys come and do whatever you want and then you leave. That's because we do not go and talk to the other professionals, what we are doing and what they're currently working on. That's right. Is there anybody who would like to add on to this? Any other challenges that you faced? Dr. Nidhi, do you like to comment on it?
Yeah, I can go next.
Yes,
so this is just my perspective. So can you hear me?
Yes. Yeah, we can hear you. Yeah, we can hear you.
Okay. Yeah, thank you. So one thing that I found is like, we don't have a sufficient number of therapists, be the physios or OTs or speech therapists. So whosoever goes, the patient, whosoever they go to the therapist first, they want to own the patient. So they don't want to, refer the patient to a PT or OT. They just say to themselves, like, we will manage the physio, or we will do the speech. I don't know. I've seen in some of the practices, and they want to own the patient themselves. So, that is one thing that I have found. And the second thing is this, echoing the point with Dr. Murli and ma'am was saying. So in a formal hospital setup, you have a intercollaboration that's happening because the patient is within the hospital premises and you have an opportunity to go and meet the doctor, physician, or other therapist. But when it comes to the private setup, I don't know how far it's possible because the patient themselves will be doing a lot of doctor shopping, and eventually, they go to different practices, and that is one of the challenges when it comes to the private practice area. So this is something, that's found in the recent years or in the past.
Okay, so we've got one more insight. Yeah, sir, you can go add on.
Sure. Just related to this discussion, I just want to bring in the perspective of, are we teaching our students to collaborate when they become practitioners? It's a big question. Do we have an interprofessional course? I mean, when I did my BOT, I remember the collaboration I had with PTs the first 2 semesters, where we did the psychology, anatomy, and physiology together. And after that, we just kind of like deviated from the path, and then we just kind of continued with it. But I think, more than putting them together in the classroom, we really need to, in fieldwork settings, or we should have some sort of a 1 credit course for interprofessional collaboration, stuff like that. So we need to actively teach them the importance of interprofessional collaboration. And, obviously, as ma'am said, no one profession can actually do everything for the patient. We need to work as a team with keeping patient in the center. So that is one thing. And the other thing that I see is that preventing interprofessional collaboration is the scope of practice issue there. It's like, you do this, it's belong to my boundary. I mean, my point is, when it comes to PT, would we all work for the patient? Even I did a survey study on scope of practice boundary violation. I really see from a regulatory perspective, yes, we need to have a clearly defined scope of practice, and which is why IOTT took that effort to, publish the, scope of practice document. And just to communicate the stakeholders in terms of what our scope is. At the same time, definitely there may be some common goals, overlapping goals with our PT partners and speech therapy partners and other professionals. So yes, you need to stay within your boundary. At the same time, we in the US we call something called like co-treating. So a PT practitioner and OT practitioner will work together with a patient. And then, where OT will do certain things with OT, like say both of the professionals want to work on balance. PT to improve their balance as one of their goal, and OT just kind of really think I want to improve the dynamic balance to encourage functional mobility and participate in the ADL and IADL, stuff like that. So there is an overlapping goal, and then we come together and co-treat, right? So those kind of things needs to be encouraged as well. And yes, I mean, definitely we need to follow back with all the referral sources, and then also collaborate. I mean, in pediatric practice, I think it is very important for us to collaborate with teachers. I don't know how many OTs in private practice and pediatric practitioners are doing this, because the child spends a lot of time in school, right? And we need to collaborate. We need to bring them as stakeholders as well. We need to bring them as part of the team. Here in school-based practice, obviously the legislation idea kind of drives that they need to have an individualized educational plan where all stakeholders need to put in their input and stuff. So yes, we need to really work from the bottom. I think start educating our students, the future workforce at least, emphasizing the importance of collaboration and maintaining professionalism. I think it's just as simple as that. Communicating back to the referral sources is a very basically it's a professionalism. It's a professional. We should have that obligation. We have that obligation to just to thank them and then provide a report on the patient, because they are believing us and sending their patients to our care. So we have that obligation to report back to them in terms of the assessment outcomes and also what the progress made by the client. So I'll stop here, and I see Rajarajeshwari's hand first. So do you want to go first before Murli?
Okay, so yeah, it was a wonderful point, and very, very, I think, very crucial point that this has to be discussed openly. Yes, like all of you have mentioned, it is very difficult, to collaborate, and many a times that there are reasons from our side, and there are reasons from the other professionals' side also. But then I believe, as a basic, core philosophy of OT, that we need to be more accommodative of every single person than any other professionals, being we are always client-centered and we look at everything as a holistic, it could be a situation, it could be a client's problem, it could be something else. So anything that we are trained to look as a whole. So the 360-degree view is something that we need to own it up. I think that I've started the minute I started practicing. I just don't know. It just became an inherent quality. Maybe the brought up or the college life gave me that. I just have no idea. So that way, your success stories are higher. You're able to succeed in pretty much all the cases that you are able to take it up. But the thing is that I haven't worked in a big hospital setup and all that, so maybe I'm really not sure about that. But in a school environment like Karthik that you mentioned, when we have all the stakeholders in single plate and a single platform, the child flourishes like anything, and I'm living that dream. Before it used to be clinical practice for me, and since now I'm here at the school, that I'm able to communicate with the parents and the teachers and all, OT team. So all of us are on the same platform, and in that way, the goals are taken care of very quickly, and the child flourishes so well. Thank you for that.
Yes.
And Murli, I saw your hand. You want to go next?
Hey, we will give chance to other one. I think Maheshwari opened up.
And also Kripa, there is Ram Kumar who has not yet introduced, and then also Anbu Daniel who hasn't. So if you want to give, after Maheshwari's turn, if you want to ask them to introduce and then share their perspectives, that'll be great.
Yes, once Maheshwari's turn, Dr. Maheshwari's turn is over, I would like to invite Dr. Benny and Dr. Ram Kumar to introduce themselves. Yeah, Maheshwari, you can go on.
Yes, ma'am. Thank you, ma'am. So I would like to add on about the challenges. So the main element is missing is the direct form of communication. We may be able to communicate through mails or letters in all the formal way of communication, but with in considering the time as well as the hierarchy in terms of the doctors as well as the co-therapists in the rehab team, physical therapist or the speech therapist. So mainly in terms of time, we will not be able to communicate directly with them. Only through this, maybe through the reports, whatever have been about the patient, we are taking into consideration and we are coming to an evaluation about what is the current goal taken by the other professionals and our goal. So in that way, we are able to segregate each of the roles. One more thing I would like to add on about what Karthik sir has mentioned, professional boundaries. So many a times when we get a referral from a higher professional, like even a psychiatrist or the physiatrist, their perspective about a child, even they consider the child comes under autistic domain. As an OT, if we see additional diagnosis as well in terms of mental health, we would see the child may be showing some other symptoms rather than ASD. So since as a pediatrician, they may they may evaluate the child of having the autistic symptoms, but we may see the child having other symptoms. So when we collaborate in such a terms, it will be like we are showing off our thing, like we are dominating them as such. Even though we got referral from them and they are considered as a hierarchy in the team, it will be considered as we are like dominating them in terms of words as well as in the point of view that we are correct and they are wrong. In such a case, it will be challenging rather than accepting that diagnosis and taking our own view of carrying on the child. So one more thing, when we are about to go back to them, when we observe some progress in the child or any of the client, so this kind of miscommunication in terms of diagnosis in any problems that may again cause a problem, that may again make us to not to seek them again, like in terms of communication.
Okay, I understand that. So yeah, when this topic came up, or when I chose this topic, the first thing that came up to my mind was professional boundary. So I feel that's one of the main reasons that we are not able to collaborate with others, or even when in the private setting I was working, if I go tell the speech therapist that like I see the child has this problem or the parent communicated this thing to me, they aren't ready to work on it, or they would say that no, that's not my area of practice. You have to work on it. Or even the special educationists, when we say that, so when we have a good understanding of the other professionals role, and also like where we would like to contribute, I think we can do a very good job in bringing the client's outcome very fast. Yeah, so that being said, we have two new participants, so I would like to call Dr. Benny to invite himself.
Hello everyone, this is Benny here. So I'm an occupational therapist. So now I'm doing my MSc Advanced Occupation Therapy back in at the University of Northampton. Yeah, so this is about me.
Okay. Would you like to comment on the challenges or that we face in collaborating with other professionals in India?
Yeah. So actually, when I saw the flyer, so it was really an interesting topic. So that's the reason I just wanted to get the reviews about the same thing with the senior professionals. So first and foremost, I guess last year I was working in a private setup. It is a ABA setup, ABA setup. So initially things were going on fine, but as you mentioned, the professional boundaries. So what happened is basically they started dominating. So they just made my boundary very little. They made just they told that, yeah, your part is just working on sensory. Do not move away from it. So these are the few challenges what I really faced over there. And even when we start speaking about the occupations or the day ADL or something like that, they are not able to take it. So I have a question to the senior therapist that how do we like get away from the situation, or how do we handle the situation basically?
Okay. Anybody would like to go on with that, or we'll quickly ask Dr. Ramkumar to introduce himself? And
let's go with Ramkumar's introduction, and then we'll follow back on this question.
Dr. Ramkumar.
Yeah, thanks. Thanks, Karthik, and then thanks, Kripa, for asking me to introduce. It's a nice topic in this platform to discuss more on this collaborative practice. Am I audible to you, or?
Yes, sir, you're audible. You're audible.
Yeah, thank you. See, in importance to our inter-institutional coordination or collaborative efforts, first of all, we need to know where we are exactly right now. There is no, for example, we are talking about ADL. For in Western universities and all, there is an ADL lab is there. If a layman is coming to a practice setup, private sector, so here the layman is seeing is coming with a problem. For example, our parent is coming with a child. So physio also treating in the physio bowl, therapy bowl, and then the same OT also treating in the therapy bowl. So they will have an option, either here or there I will go and take the session. So this kind of things and all needs to be changed by show some marked differentiation in the practice. So labs, well-established labs, and then sensitive investigation measures. We need to move away from the paper pencil based assessment, and we need some, for example, pegboard and all need to be quantified in a sensitive way. Purdue pegboard we are using for a long time. How it has to be graded in the electrically or electronically graphs. And then we need to be many more movement analysis. Many things are there, and we need to get collaborated with other engineering faculty, biomedical faculty. Lot of projects and all needs to be explored. For that, the faculty in charge, that is the dean or whoever it may be, have a very wide, generous mind to accept these kind of ideas, and they should not be very narrow-minded. First of all, then only under them there are 560, 550 graduates are going to come out. They will know with more amount, abundance, plethora of knowledge. So that is highly restricted. One particular example that I told. So these are all the areas needs to be corrected at the earliest, as immediately as possible.
Thank you for sharing your perspectives. So Kripa, let me just kind of briefly answer Benny's question, and then we'll continue with the discussion.
Yes, sure.
So Benny, like I think your question is in an interprofessional setting, what should we do, or how we should assert and advocate for ourselves when we are very much narrowed to a particular niche, right? So, first of all, we need to understand one thing is, definitely there are some overlaps. When we try to do some behavioral interventions, there is an overlap with behavioral therapists. And when we do some, work with patients with physical dysfunctions, there are some overlaps in terms of our goals along with our PT colleagues. So first of all, I think, we need to start and we need to understand that we need to respect each other's expertise. right? We need to really respect, in order to gain respect, I think we should also respect other professionals first. And then when they say like, you have to do only this, then, it is more of their lack of awareness in terms of how much, we learn in those aspects as well. So I think the best way for you to defend yourself is basically, I appreciate that, you're a behavioral therapist and you have this knowledge in this, but as part of our education, we also cover these aspects. Let me see how we can collaborate and help the patient together, instead of, let me do this, you should not do that. So let's, instead of dividing, and then try to collaborate with them, and then like try to change the conversation. And also, once you demonstrate your skill in that area, you never know, like, there are settings where, a particular person is really skillful in doing a particular task or activity or intervention. Even though a PT can do the same intervention, OT can do the same intervention, if the person demonstrated his or her skill set, the other person is ready to willing to, okay, I think you are good in that, you take it up, that I will work on this other goal. I've seen that in my practice where, a particular therapist demonstrated a great skill, and it's so natural for the person to really do it well. So here we need to ask the question is, what is the client problem, and who can, do the best stuff? And in terms of, we need to respect the expertise. Say, for example, you are kind of like in the beginning stages of using behavioral intervention, where that person is already working with a particular client for 6 months already. The person may know the client better, and you can say that, these are my expertise. Is there a way that I can assist you in what you're doing? Right. So I think we need to just kind of change that attitude and approach a little bit and educate the stakeholders. And it's oftentimes it's basically that it is not that they want to put us in the narrow corner. They do not know actually what we learn, what we do. So their perspective of OTs do sensory integration. That's a narrow mindset, and the fault is on us. We haven't really educated the stakeholders that much. We need to publish, we need to produce case studies. There are so many of you working in multiple settings. How many of you have taken time to document a success story in a magazine or in a journal or something? I think once we do more of these, more we document, I think, then our role will become more visible, and then people will appreciate what we do, how we bring valuable outcomes. So it's a long way, but I think to give you an answer within a building, I would say just change your approach a little bit. Try to be more welcoming and collaborative. That will definitely make a change, unless the other person is totally narcissistic. Murali.
Hi. This might probably address both Mageshwari's thoughts and as well as Benny's thoughts. Now, I definitely agree on the aspects where Thiru suggested and said. See, I fortunately now I have this experience of working with the medicos as parents of my center, where there is a pediatric surgeon, there is a pediatrician, there is a dermatologist, there is a general surgeon, there is a psychiatrist, aspiring the final year psychiatrist, all that. But the continuous feedback I have got from them is they have in MBBS, there is only one paragraph of occupational therapy. That's it. They don't have anything on occupational therapy in the MBBS syllabus. And being a psychiatrist, she told she has nothing on occupational therapy except on autism. There is one paragraph in her syllabus. That's what she has. And imagine she's doing her in the most renowned government psychiatric hospital in Chennai. But at the same time, they don't know, even though their kids have an issue, but they have no clue what we exactly do till they come across it. But through this, I have come across some pediatric psychiatrist, a child psychiatrist who handles the cases. And then like I happened to send the psychiatrist the report of this particular child after 3 months because they were going for a review. And initially I didn't give because it came through a different source to me. So I sent the initial report to a speech therapist who sent me the child. And then since they were going for a review with the psychiatrist, I sent him a report saying this is what the initial report was, this is the progress, and my future goals are these. So when he saw this, and then he reached out and told me like, who are you? First thing is like, where are you graduated? What it is? He didn't even talk about the child or stuff. What he was more curious was the report. He said, I'm impressed with your report, so I want to talk to you and see, I can send you clients. So I had no clue, because what I sent him was a very brief 2-page report, not even a full assessment, So I wasn't happy with my own report. It was just an emergency report which I was given. But if he can be so happy with that amount of report with goals set, that means that's a lack from our part, that we are not sending them the work, what we have been doing, what are the goals we are setting, or what home plans we have given for the parent and they are following. So since then, he is like reaching out to me every time, even for the clients who are going therapy somewhere else, he's sending for a second review assessment, only assessment, and then they go back. The same thing happened with another pediatrician. Your report is good, so I'm sending the clients to you. These people have never sent me referred clients before. Somehow I send them a report. Now they are referring me children. So what it implies is they have no idea what exactly or how exactly we are working. And they would be happy to know that we are really working with the kids in these areas. So when they are aware that we are working for them, they would definitely be able to communicate with us easily. And I definitely agree with Maheshwari's thought on more than reports. Calling up or going and meeting them in person would give a better clarity on what we are working, and then they would understand us better. Same example, when I spoke to the psychiatrist, I told him I do work with psychiatric clients, where vocationally settling them and working on their life skills, young adults with sensory issues, autism and ADHD. Now I have psychiatric clients who are adults, 25 and 30-year-old, coming out of autism or ADHD, settling them in their job or ADL skills. Particularly, there is this new person who's a person with autism. She reached out to me and said, like, I came to know through my psychiatrist that I need to come and meet you for remembering to brush in the night and going to sleep, regulate my sleep time in the night. And this particularly referred by the psychiatrist. So, till then, they had no clue. And even I didn't know that I can talk to a psychiatrist only on this aspect and ask him to refer the client also. But this is one specific, like, super specialty area of working kind of. So we reaching out, telling people, making sure they are aware of whatever the capabilities we have, of course, ours is like a 1,000-hand spread wing, banyan tree kind of a profession. We need to tell people that these are all the areas we can work specifically for each profession. So me and a friend of mine, Gopal, have come up with Gopal Mani and others. We have come up with one idea where different fields will have different goals from the occupational therapy. So we are making a pamphlet for orthopedicians, rheumatologists separately, because we do deal with low back pain and then arthritis as well. So for them, the OT's work needs to be specific, related to their field of interest. So when you're talking to any professional, related to their profession, not just the pediatrics or not just the neuro or not just the ortho. So reaching out to them in their own term will make them understand better.
Beautiful one, sir. So I would just like to wrap up the conversation that we had. Like, I would like to just brief the points, and then I will come back to Pooja, Dr. Pooja, and Dr.
I want to remind you that Pooja is here. If you just want to hear from her briefly in terms of her thoughts about interprofessional practice. But before that, just a couple of things I want to reiterate. One, I literally agree with what Murali said. I enjoyed the same thing 15 years ago when I had my practice, where I gave a report and that triggered me a lot more referrals and respect from the medical professionals and specialists. Number one. Number two, is basically that we really need to work at the systems level as well. We need to educate the stakeholders, and the better way to do is, like, in addition to circulating how best OT is or what OT can do among OTs, we need to expand our breadth to other professionals. And I think that's where the interprofessional practice is a key aspect, where while you're working in your own setting, you can be an advocate in your own setting and try to work with others, thereby they become more aware of what OT can do. With that, I'll just kind of leave the control back to Kriba.
Yeah, I'll just list out the points that we have discussed till now. So the challenges that all of you have mentioned is that we lack of initiation from the occupational therapist side and lack of follow-up to the referral source. That is another thing. And Dr. Thiru sir has said owning clients to themselves or owning clients to a particular profession. That is another major challenge that we've seen, and professional boundary a lot of areas, and also no direct communication, direct form of communication with the other professionals. So that being said, we also discussed little steps and measures to, alleviate this. So OT should be more welcoming and educate students right from their UG level, so that they would be open up to discuss about themselves, about their scope of practice to the other professionals, and they'll be more welcoming to the other professional as well, and to collaborate with the teachers and all the stakeholders in the right way. So we miss out the major stakeholders in most of the areas of practice wherever we need to. So that we need to do it, and proper documentation. So that as Murli sir has said, so a small documentation actually can do a lot of difference in the stakeholders. So that we need to have in mind. And also the last thing, to advocate and educate about OT, where are things we work to everyone, that would also help us to collaborate more and to know more about OT from their, from their perspective. So that being said, I would like to invite Dr. Pooja to introduce herself and also share her thoughts.
Hi, good evening. Can you hear me?
Yes.
Yes.
Yeah, clear? Okay, so sorry first that I joined late, but I agree with both Karthik sir and Murali sir's points and the summarization that Kiruba has done, that yes, we need to put a small documentation whenever a patient is referred to us. But I do one more thing as well. I generally give them a call as well, the referring doctor or the teacher or the school counselor or the speech therapist or whoever is referring, even psychiatrist, give a small, call back, or even a WhatsApp message would do. Because most of the times, what I have seen is that we give report, but it doesn't reach the doctor. It doesn't reach the referral person. Most of the times they don't take it to the, referring doctor, or they don't put it in the file. The reports are not properly managed by the parents. So, I mean, I have a pediatric practice. So, sorry, I am Pooja Mehta. I'm a pediatric occupational therapist. I have a clinic. I'm a private practitioner, standalone clinic here, since past 12 years. So, yeah, I mean, so I do give, a small note on WhatsApp, or I give a quick call, depending on how comfortable the referral person is. Okay, so I even sometimes, give a quick call to school counselors who are referring, because most of the time school counselors are the one who are, least in the loop, because they generally send that, the child should go for OT. And since very few schools in Mumbai have OT centers, so most of them go out, I mean, in the private clinics. So school counselors don't know whether the child is going to an OT or is not going. Parents sometimes say that, okay, we have gone, but, report nahi dete. Sometimes parents do tell that as well. So to avoid all that loop, because I have worked in a school-based setting for 3 years, so I know what happens in the school scenario as well. So I give them a quick call to ensure and to keep them in a loop that yes, the child has come for consultation, assessment is done, and we'll start therapy. And after a few months, that this is the brief points of improvement I've seen. I've sent the report with the parent. You can ask for. So this is a brief, thing that we generally I have the habit of sending, in order to, have a common page thing. So because every time, sending those lengthy assessment reports and everything, it's pretty time consuming. So even I end up making short. So when I started clinic long back, I used to write, 6 to 7 page reports. But now I've come down to 2 to 3 page reports, because report is must, I would say, at least that kind of But yeah, I mean, the reports that are required for LD assessment, I give a full length report of 6 to 7 page till date. So at least that part. So this is the way I collaborate in my practice.
Got it. No, I mean, like basically, we need to understand that we don't have to give the NT assessment to other professionals. That is not actually expected. Even for if you ask for an X-ray report or MRI report, they just give that one-page summary. So we need to, as a professional, we need to clinical reason and then do the assessment of the findings of the report and provide them a summary report in a very simple language. So that other professionals can understand. We don't really have to, provide a detailed assessment report unless it's been asked for some sort of insurance reimbursement or something like that. So having said that, again, it's time. It's been almost an hour. So Kriba, we want to thank the participants. And before that, I really appreciate all of you being here on behalf of IOTTT. And I look forward to seeing you in our future Saturday night chats as well. So Kriba, please wrap up.
Yes, thank you all of you for joining this discussion. And I think we had a very good, insightful discussion, and we all have now understood what are the challenges that we face in the interprofessional collaboration, and also where we should be working on. Yes, I think we haven't heard from Nidhi. Dr. Nidhi, would you like to contribute? Yes. Yeah. Go on, Nidhi.
Yes. Thank you, ma'am, for the opportunity, and sorry for interrupting you in the middle. So I just thought, I just had this thought in mind that a lot of doctors, as Karthik sir also mentioned, a lot of physicians, a lot of other professionals are not aware of exactly what we do. That is one challenge. And even if they're aware of what we do, they don't know how to approach us, from where to contact us. They I want to refer to an occupational therapist, but I don't know to whom to refer and how do we contact. So if we are able to have city-wise or state-wise directories which are available online or on reliable sources, that would be extremely helpful for people to refer clients to us. That being said about the referral, similarly, as far as my knowledge goes, a directory is being built by where all the allied healthcare professionals are being brought under one common platform, and a directory is being built. So if that is accessible to all professionals, we will also have the ease of finding out who people are, how do we refer to other people, and then collaborate and practice in an interdisciplinary collaborative practice.
That's a great point to add on. Yeah, thank you, Nidhi. Yeah, so now I think we've heard from everybody and we had a very great discussion. I thank one and all for joining this session, and I invite you all for the future discussions with IOTTT. And yes, have a great day. Thank you everyone for joining.
Well done, Kriba. Thank you so much. Bye, everyone.
Good job, everyone. Thank you so much. Have a good weekend.
Bye. Thank you.
Bye-bye. I'm ending the meeting for everyone. Bye-bye.